Greetings. Tonight we're going to briefly go through the voluntary withdrawal of Ocaliva or obeticholic acid for PBC for the interest of our viewers. I'm Robert Brown from Weill Cornell Medicine, and I'm joined this evening by Patrick Horne from the University of Florida in Gainesville. This program was provided for by an educational grant from Intercept, though they had no control of the content. I'm waiting a moment, Patrick, though I think maybe you do need to advance the slides for me. So why don't we go on to the next one. Here are our disclosures. We both do consult for Intercept and help them develop this slide deck. Next. So as many of you were wondering, and I think probably Patrick and I were wondering when it first came out, why was Ocaliva voluntarily withdrawn from the U.S. market for PBC by Intercept? And I think we've learned, and we're going to share with you this evening, the reasons behind that, as well as what the steps you can and probably should take in managing your patients. So it's important to note that Ocaliva or obeticholic acid was not involuntarily withdrawn. It was removed on a voluntary basis by Intercept after a withdrawal request that was received from the FDA. The FDA, in making this withdrawal request, cited the following pieces of data. First, that as was discussed at the GI Drug Advisory Committee meeting, or GI DAC, the confirmatory COBALT clinical trial, which was a randomized controlled trial between Ocaliva and placebo, which was intended to get full approval, did not meet its primary endpoint, meaning it failed to demonstrate that obeticholic acid improved liver-related outcomes compared to placebo in the RCT, which was what was required to go from accelerated approval to full approval. Additionally, the December 2024 drug safety communication identified cases of serious liver injury among patients treated for PBC with Ocaliva, who, at least based on the records review, did not clearly have cirrhosis of the liver. This led the FDA to reevaluate the drug's risk-benefit profile, and because it was not on a accelerated approval or conditional approval, they recommended removing it from the market. Next. Oh, Patrick, now can neither you nor I control the slides?
I think you, let's see.
Oh, there we go. So, nope. Go back to the next one. So, what was this safety communication, and what specific data did the FDA highlight that tilted the risk-benefit analysis? And this was based on that December 2024 drug safety communication. Nothing happened between the GI Drug Advisory Committee, where the FDA voted not to give full approval to Ocaliva, and the December letter and September of 2025. So in that interval between the meeting and this letter and this action, there was no new acute safety signal that emerged that wasn't discussed in the GI Drug Advisory Board Committee and communicated to providers in December of 2024. Next. So when you look at the quantification of risk, it's important to note that this was patients who had been in post-marketing data, where they noted that non-cirrhotic patients who were receiving OCA had an increased risk of liver transplant and death compared to those receiving placebo. Now, this was after they had either completed the trial or were often in long-term follow-up. The hazard ratio was listed as 4.77 for serious liver injury in patients without cirrhosis. But it's critical to note that though statistically significant, it was a very small number of events, 7 in the OCA arm and 1 in the placebo arm, leading to an incredibly large confidence interval that you can see here, which basically goes from almost no increased risk, a hazard ratio of 1.03, to a 22-fold increased risk with a hazard ratio of 22.09. And this means that, of course, the risk estimate is unstable. And the fact that many of these patients were outside the trial at the time of the event and may have had progression of disease has potential confounding factors. Many had been withdrawn from the trial and placed on commercial Ocaliva. Despite this, given that there was a 7-to-1 number, the FDA concluded that the risk to benefit ratio was not favorable, given that the COBALT study did not confirm benefit and this potential for increased risk. Next. So what does that leave us with as providers and our patients with who are on Ocaliva? My questions when this first came out is, what is the timeline? And should we, do we have to make patients come in immediately? And so I think it's important to note that Ocaliva will no longer be commercially available in the U.S. after November 14th, 2025. So depending on whether you give a 3-month supply or 1-month supply, probably by January, there will be no more Ocaliva available. Second is patients who are currently on Ocaliva should not panic. They are not in imminent danger, and like all medications, should not discontinue therapy without consulting with their healthcare provider, you or whoever prescribed it. Next. So how do we recommend discontinuation and pharmacological management? Next. Well, first, I think this is the simplest thing is don't start new patients on Ocaliva. Starting when they're going to have to stop immediately is not wise. 2 is really identify who are your patients on Ocaliva, and at least with each of them, make a transition plan, whether this means taking them off therapy and observing them or converting to another second-line therapy. And certainly for patients who have indications for second-line therapy, and that's why they're on Ocaliva, the vast majority should be transitioned to another second-line therapy in a timely manner. One might presume within 60 days, which will give you time to get insurance authorization and get them medications so they don't have a gap in care. Next. So do you have to taper them? Is there a risk for a flare or withdrawal? And the answer is no. You don't need to taper the dose. It can be discontinued. As an FXR agonist, Ocaliva does not have physiologic dependence, and there is no rebound effect where the alk phos will go up higher than it was prior to therapy. There have been no reports of withdrawal syndromes in the clinical trials or in the literature. Next. So there is a short half-life. And so you do not need a formal washout period before starting a second-line agent. The half-life is about 4 days. So the drug will completely wash out of the system within 2 weeks. But there is no need for a washout period or tapering of OCA prior to starting a new treatment because of their non-overlapping and completely different mechanisms of action. Next. So why not just stop and see what happens? And the answer is that there will be a loss of a therapeutic benefit. If patients were on Ocaliva because of inadequate response to URSO, discontinuation of therapy will cause a loss of benefit. And this means that alk phos will rise to pretreatment levels. And of course, that will give them a higher risk trajectory. Is this happen fast? No, you will have time to assess and to get new therapy. But in general, what I view is that when patients are motivated, doing well on therapy, it's probably wiser to transition them directly to another second line agent than let their alk phos go back up and then have to restart. But it is expected that within months of discontinuation, any benefits of taking Ocaliva will be lost in terms of disease trajectory. Of course, stabilization or regression of prior disease, that benefit will not be lost, but will be slowly lost due to an increased risk of disease progression over the ensuing months. Next. Now, what about symptoms? I think you shouldn't expect a change in symptoms, especially pruritus. Of course, pruritus is the most common side effect observed in patients on obeticholic acid at a higher rate than on placebo. So one would expect that pruritus would be either the same or improved with discontinuation. It may not worsen and it may not get better, but it should not worsen. It should stay the same or get better. There is no data on worsening of fatigue or quality of life after discontinuing obeticholic acid. Really, what one should expect is either no change in symptoms or an improvement in pruritus, but a loss of biochemical benefit. Next. So I'm going to now turn it over to Patrick, who will take over for monitoring and alternative therapies, and I will rejoin when we get to the Q&A.
Thanks, Dr. Brown, and good evening, everybody. Thanks for joining us. So as Dr. Brown said, I'm going to take us through the last few slides, starting with monitoring and alternative therapies. So as Dr. Brown already said, we expect that there would be a change in the biochemical markers once you discontinue OCA. So what does the monitoring of that look like? So when we're talking about sort of consensus-driven schedule for monitoring post-discontinuation, obviously the ALP and the bilirubin are the accepted surrogate markers for long-term outcomes in PBC. I think we all know that. And as Dr. Brown alluded to, stopping OCA will probably lead to a worsening of these markers somewhere within weeks to possibly months, depending on the patient. So in order to sort of monitor their disease course or disease progression, it's being recommended that you repeat the ALP, the bilirubin, as well as the ALT and AST about every 12 weeks. And then from that point on, every 3 to 6 months. So what are the necessary components for clinical and imaging surveillance? Well, obviously, you want to monitor for any potential side effects. As Dr. Brown alluded to, monitor for changes in pruritus. Though it should not worsen with the discontinuation of OCA, it may not improve. It may stay the same. You do want to monitor for changes in fatigue. And then for patients who either have cirrhosis or maybe have advanced fibrosis, you obviously want to monitor for those signs of decompensation, jaundice, ascites, encephalopathy, etc. There is no immediate imaging that is required solely related to the patient stopping OCA. Obviously, with patients who have known cirrhosis, they should continue their HCC screening and surveillance per the current guidelines. And for patients who have advanced fibrosis, consider fibrosis reassessment, such as with transient elastography per the standard PBC guidelines. So we're going to talk a little bit about second line. So as you may or may not be aware, there are two other second line therapies that are now FDA approved. And what are these? So the two other second line approved therapies for PBC are elafibranor and seladelpar. So we would encourage that all patients currently on Ocaliva be proactive and contact their providers, or have the providers reach out to them to discuss one of these alternative therapeutics. Just to kind of highlight the difference in mechanism of action, as Dr. Brown mentioned, Ocaliva is an FXR agonist. Elafibranor and seladelpar are completely different classes than that. So elafibranor is a dual PPAR, both alpha and delta agonist, and then seladelpar is a selective PPAR delta agonist. So different mechanism of action, different profile than OCA. So just make sure you are aware of that. What about overlapping drug and drug interaction profiles? So again, to reiterate this key point, there is no need to overlap or bridge between therapy with Ocaliva and a new second-line therapy. There's no indication to do that. Clinically significant drug interactions with either elafibranor or seladelpar are not anticipated. Both drugs are very well tolerated with a very good safety profile. But it is important to speak with the patients to determine the appropriate next steps and what is the timing of that. As Dr. Brown mentioned, Ocaliva will no longer be available as of November 14th. So as of from today, essentially about 1 month from now. So let's talk a little bit about safety, access, and then we'll do a quick summary, and then we'll get to the Q&A. So safety for patients who are currently on Ocaliva and are tolerating it well. So we do want to reiterate that patients who are currently on Ocaliva and doing well, there is no immediate safety concern, and that's not what led to this discontinuation. There were no additional safety or acute safety signals identified that led to this. This was a voluntary withdrawal based on a request from the FDA, but there were no new safety signals or safety concerns with Ocaliva in patients who were already meeting the criteria for therapy and were tolerating it well. Patients who have been appropriately monitored, both with their labs and fibrosis that have remained stable, did not suffer any harm, and should proceed with the transition to an alternative FDA-approved therapy to maintain a biochemical response, as Dr. Brown had mentioned. So monitoring for adverse events during transition. So with any transition, starting any new drug, as you all know, we should monitor very closely for the potential for adverse events, though we expect those would be rare. Monitoring for adverse events obviously is important anytime a new drug is being started, especially as a second line. And you should report any suspected adverse events that you feel are associated with either the discontinuation or the transition, though again, we do not expect there to be any overlap or issue with transitioning from Ocaliva to a different second line therapy. Access and insurance considerations. So a big question is, what will insurance and insurance coverage, how will they handle this change, and what can we tell our patients? So with Ocaliva's withdrawal, this does mean most likely that some insurers will no longer want to pay for Ocaliva, given the pending date of November 14th when it will no longer be available. And as we've said several times, patients should work with their providers, but also their insurers to manage the coverage approval process, specifically prior authorizations for a new second-line therapy. Providers can direct patients who have concerns to the Interconnect patient portal support services from Intercept. They can help assist with some of this if needed. And then for communication and clinical resources, these are some clinical numbers for both clinical and medical information if needed during this transition. So the Intercept medical number is 1-844-782-4278. And then that Interconnect Patient Support Services number is 844-622-4278. So just to summarize what we've kind of gone over here briefly tonight, the withdrawal was due to an updated risk-benefit assessment, but not due to an acute or new safety event. It is being recommended that patients transition to an alternative therapy by November 14th of 2025, as that is the date that Ocaliva will no longer be available on the market. There is no taper or washout needed, and they should see personal provider. The patients should see their personal provider for guidance on starting a second-line therapy, whether that be elafibranor or seladelpar. And again, the key risk with a patient discontinuing Ocaliva, as you would expect, there is expected to be a loss of biochemical control and a return to the higher risk disease trajectory. Though, as Dr. Brown mentioned, that is not going to be a fast process. But to mitigate this, it's recommended with appropriate monitoring and assessment for a transition to one of these second-line therapies as soon as possible. And with that, I think we'll open it up for the Q&A.
Great. So we already have one question. Is there any clinical evidence that elafibranor or seladelpar should be favored in PBC patients discontinuing obeticholic acid? I think we can each give our opinion. I think this is no different than the decision of which drug to choose in patients who have indications for second-line therapy who are not on obeticholic acid, but are having an inadequate response to urso. I think they are both PPAR agonists, though, as Patrick highlighted, one is a dual PPAR and one is not. There are some small differences in the data from their clinical trials, though, of course, it is important to note that neither one is approved head-to-head. Seladelpar does have improving pruritus in their label, which may be an advantage. I think that you have to make an individual choice